Deze podcast is mede mogelijk gemaakt door de vriendelijke steun van Dr. Paul Hoebe en zijn team. Dank daarvoor.
Hello and welcome to the Medici Compass, the medical podcast from the Netherlands. In each episode we dive into a medical case or topic with leading experts and specialists. I'm Henry.
And I'm Christiana.
Today we're recording from Kuwait with Dr. Hisham Alkhayat. Dr. Hisham Alkhayat studied his degree in medicine at Kuwait University Faculty of Medicine, after which he followed residency in neurosurgery at the University of Miami. Thereafter, he followed a fellowship in spine and joint surgery from the University of Miami and a fellowship in oncology and vascular disease from the University of Dallas, Texas. Dr. Hisham Alkhayat is American and Canadian board certified with over 20 years of experience. He practices in Kuwait with a focus on improving services in the region, where he specializes in minimally invasive and endoscopic interventions. We'd like to start off asking you a question. Is there a doctor who's inspired you in your training or when you were becoming a doctor that you could share with us?
Yes, during my career, you have during your university, you meet a lot of doctors. And the good thing while in your study, that each one will make change in your life, in the way you're thinking, the way in your style, your lifestyle. You take a little bit from each one. And this will change it a lot. The main one who changed my career is Dr. Roberto Hero. He was the chairman of University of Miami. He's a cerebrovascular surgeon. He used to come every day in the morning. We discuss the cases every day during 6 years, my residency. Every day in the morning, he come and we discuss the cases and we share from his experience, and he learned from us and we learn from him. And this is a great thing. In medicine, you need to keep up with the information, and how you do this by exchange the information with each other. And this is very good, because this is how you keep up with the rapid change in science and medicine.
The sharing of the information is quite a powerful thing then for you in your development,
because this is how you keep the information. You keep it up by exchange the information, and then you keep you have a wide view of the things. We have things that there's so many ways to skin a sheep or something, so you learn it, so you see the easiest way, and then you learn there's different techniques. And then you build up your own practice which can fit in your community. In Kuwait, for example, the way you deal with the patient different than in Netherlands or in Europe or in the United States. So again, the doctor have to accommodate where the place he's working in, and how you accommodate by looking to the other experience. So you don't need to reinvent the wheel again. You need to start where they stop, and then you just try to improve everything.
I think this is a great moment to start with the case, right?
Sure.
Okay, so a 62-year-old man with a history of smoking, prostate cancer, and chronic kidney disease. He had a left nephrectomy. He's receiving renal replacement therapy with intermittent hemodialysis 3 times a week. He had right pyelonephritis with exacerbated chronic renal failure for the past 3 months, which has progressed to septic shock caused by Candida tropicalis and Pseudomonas aeruginosa the past month. He consulted for intense lower back pain that had been evolving for a month. So we have this 26-year-old male coming to you.
Clinic, yes.
Yeah. Well, what do you think? What is the first thing that you do?
So the patient, what you're describing, is having a lot of comorbid illness, that his renal transplant, he's doing now hemodialysis. All these will decrease his immunity and make him susceptible to one thing. The first thing ringing in your mind, some form of discitis or inflammation in the back. Now, if this pain persists and it doesn't go with a painkiller, regular painkiller like paracetamol or anything, and it's affecting his lifestyle, he cannot turn in bed, a severe spasm, then the first suspicion we think of is discitis. You have to rule out discitis. There is certain red flags that we talk about, in your residency, that if the patient have it, then you need to think about something serious. That intense pain that doesn't go with the medication, if you're having fever, night sweats, spasm that affect his lifestyle and doesn't go away. Usually if you have muscle spasm, usually it will go within 2-3 days. But if it persist, then there's something wrong. Then he need to be investigated. Now, if it's pain, we ask him, is it mechanical pain? Is it affecting his walking? No, I cannot move. I cannot turn in bed. My back is stiff. Then we think of discitis.
Okay, perfect. So you said that you give paracetamol. So I can imagine the first consult he comes, you give the medication. How long do you wait?
Usually, we tell them within 48 hours. You give them some muscle relaxant, like baclofen, Leursal, and also a dole and see how it responds. And usually, we ask for the red flags, as I told you before, like if you have fever, if you have night sweats, if this pain is persist and doesn't go away, that's affecting his lifestyle, daily lifestyle, like going to the bathroom, changing, going to the cars, stepping out from the car, is very painful. Then you ask of course, you ask if there's trauma. This guy, the one you described, he had renal transplant. Now he's doing hemodialysis, so he's exposed to septicemia. He wasn't having septicemia, so there's some bacteria in the blood itself. Now, these organisms sometimes can hide, and we have certain place in the body they want to hide. Always they want to survive. As you want to survive, these germs want to survive, and the best way where they survive is in the disc space, because this, as you know, the cartilage doesn't have blood supply. They get the nourishment from the end plate, so they can hide there. And once they can make like a colony for them, and they start doing some form of inflammation. This inflammation will cause this kind of pain. So of course, if you're having renal dialysis, septicemia, now coming with severe spasm that doesn't go, of course, he will try the over-counter medication, but he's having this severe pain. Then we check him. And the best way to do it is to do this sometimes lab tests to check it out.
And before you check that out, do you also do some look at his body? Do you tap on his back, or do you do some tests?
We tell them, where is this pain? Usually they describe their pain. Does it radiate to the leg? And this is important because when it radiates to the leg, this means that there's some compression on the nerve itself. And check his neural exam. Of course, we tell them, usually we can do quick neural exam. We tell them, step in your toes, walk on your heel. Now, if they can do that, this means that the L5 and S1 nerve roots is intact. And of course, you ask him, does it affect your urination? Of course, this guy's in hemodialysis, so he doesn't urinate, but there is like numbness, tingling in the saddle area? Then you're looking for some spine compression in the spinal cord. Now, if he doesn't, the pain is mainly in the back. You check if there's spasm. You ask him about the range of movement. Can he move around, sit around? No, the guy is stiff. He cannot turn around. Then this means that there's severe spasm.
Okay, perfect. And then you said about the endoscopic or the.
No, usually, if we think of this one, the first thing we do lab test. And then we look for, if you want to suspect some Discitis, we look for some inflammatory marker, which is the ESR, CRB, and BCT. And these are indirect measures that will help you if there's some form of inflammation. Usually those with Discitis, they have very high ESR and CRB.
Yeah, we have those values for you in a minute. I have a question. So Discitis is now high on the differential. What else is there? And do you have anything that you want to...
The other things, of course, this is the first one. The other differential, you keep it in mind. This guy is hemodialysis, he was in prednisolone. So you think of osteoporosis fracture. So you think to keep it in mind that this could be acute fracture. That sometimes, he didn't describe trauma, he didn't have trauma, but sometimes when he cough or sneeze, or sometimes like slight fall, this can cause fracture. So the other possibility you have to keep it in mind, this could be osteoporosis fractures. Of course, this guy have a tumor. This could be a metastasis. Again, you're looking for something for the back. We think first is usually muscle, but if they have a pathological disorder, like before, you have septicemia, then you think Discitis. If you have osteoporosis, you think of fracture. If you have a tumor, you think of metastasis. And you need to keep it in mind. And usually these will have the red flag that we talk about, that usually at night they have pain. I have to wake up at night to take some medication. This will help, guide you to where you go.
Mm-hmm. Perfect. I think it's a good moment to continue with the clinical findings. The acute lower back pain was detected, 9 out of 10, associated with paresthesias in the lower limbs. The symptoms worsened with activity and also at rest. When the thoracolumbar spinous bones were palpated, there was no pain. The cervical and lumbar regions of motions were complete. Right L4 and S1 hyperreflexia were observed, with the rest being unremarkable. In dermatomes from L1 to S1, sensitivity was preserved and symmetric.
So this is mainly mechanical and also at rest. So it more guide us with mainly fractures or infection, or could be a metastasis. But there's no compression on the spinal nerve. Usually the nerves are damaged, the paresthesia, usually because these patients are immunocompromised and they took a lot of medication. Sometimes they could have neuropathy, which could cause some numbness, but there is no neurological compression. So most likely, again, in the main differential, I could be Discitis or fracture or a tumor.
Okay, so if I understand correctly, you want to know whether there is or there is not mechanical pain. And when there's no mechanical pain, that means that there's no compression. So we think more of the areas that are not directly related to the nerves.
Yeah, usually if there is mechanical pain and not at rest, the problem when you have both of them together, this most likely there's something pathological, that even at rest, the muscle go into spasm, want to hold you in the space, doesn't want you to move. Usually because this is a kind of inflammation in that area. Usually if there's mechanical, only mechanical, but what at rest is fine, then this most likely go with a spondylolisthesis. If they have spondylolisthesis, like when they use the spine, they use it. But if it's fracture, even in fracture, when they are at rest, especially with the supraspinatus, they cannot turn in bed because the muscle itself will go into spasm, want to keep the bone in the same place. It doesn't want you to turn. But usually they will rest. Now, when they don't move, it's fine. But even if they don't move, they have pain without movement, without even turning. Then it's go more with the tumor or with infection, but it doesn't go with a fracture. But the fracture, even in bed, when they are turning it side to side and they have pain, this go with a fracture also.
Yeah, and we're thinking more of an inflammatory process.
Yes.
How do we rule out something like a rheumatoid process?
Yeah. Inflammation, good. Spondylitis, sometimes we have those patients with for ankylosing spondylitis or rheumatoid arthritis, they can have back pain, but usually their pain is usually stiffness, like when they wake up in the morning, when they turn in bed, and usually as they move, it gets better. So morning stiffness, it go more with inflammation of the rheumatological disorder. But if the pain persists all the time, morning, evening, doesn't change, this is go with something pathological that we need to look for.
Okay, due to the oncological history, a PET-CT scan was performed, which showed increased uptake in the vertebral bodies of T12, L1, and L2, and in their intervertebral disc of L1 and L2. Due to severe kidney disease, an MRI without contrast was performed, which revealed hyperintensity in L1 and L2 and ruled out compression. Laboratory analysis revealed high values of acute phase reactants like ESB, which is 110, and C-reactive protein 6.66. ESR, sorry.
Yes, sir.
Yeah. So this is what we found. So either a PET-CT has been done, an MRI, and the laboratory analysis. How would you go further with this patient?
Yeah. See, when we do the PET scan, you have to decide what kind of PET scan. We have something called PET glucose, to check whether there is tumor or there is inflammation or something. So this PET scan, if there is high metabolic activity, this means that there's increased area of inflammation in that area, or it could be tumor. So how you differentiate it? You see the uptake, where is it? Is it in the disc space? Then it's most likely an infection. When it's going in the body itself, then you think of, maybe the tumor itself. Now, if it's metastasis, usually you will have other area in the body is involved, but this is only localized. So we go more within inflammation within the disc itself. So this is the PET scan. Now, the MRI, of course, you said it's done. It showed that in the T2 that there is hyperintense signal. There is changes in the disc in the body of T12, L1, edema because of the inflammation itself. Now, the contrast, usually we don't give it to the patient who have chronic renal failure. But this guy is in hemodialysis. We can also give contrast because we know that he's going to do dialysis within tomorrow. Then it will not affect anything. Anyway, his kidney is not working well. Now, if his kidney is not functioning, or if it's not functioning, now if it's functioning but it's poor, then definitely will not give contrast. What will depend on these markers to help. Now, if again, as you said, and the MRI itself show that there is no compression, you check that the conus, because this will affect your way of treatment, whether we treat him medically or surgically. Now, there is no fractures, no deformity in the bone, there is no compression in the spinal cord, there is inflammation in the disc itself. So that one is going more with Discitis. Then we go with the ESR. As you said, the ESR, the normal ESR is 20. This is 100, is more than 5 times the normal. So this go with the inflammation. Again, ESR alone will not work. You have to get other marker to help, which is the CRB, which is high. Usually it's 4. So you go, I thought you said how much?
CRP was 6.6.
6. Is elevated, little bit elevated. So it's high. So all these go with Discitis.
Okay. So when we look at this patient now, how do you discuss the surgical or the treatment opportunities that are available?
So we think this is most likely with Discitis. When we talk about Discitis, there are 2 forms of Discitis. One, septic Discitis. So this means that there's inflammation process going on in the disc space. This could be due to bacteria or fungal or viral. So this most likely bacterial infection. This is most likely. And why? Because this guy had to have hemodialysis. He go and have IV line. It could get some bacteremia. He had history of bacteremia. So we know that this is most likely the cause. Now the bacteria, most of the bacteria that happen in this area, usually is gram-positive bacilli, is gram-positive cocci, this like Staph aureus, or gram-negative if you have urinary tract infection, then gram-negative bacilli. So we tell him, this is an inflammatory process. We need to start him in some form of antibiotic. Usually, we need to guide the antibiotic. So initially, we try him an empiric treatment, but then we guide that we need to take like a CT-guided biopsy for that lesion to see whether we can find the organism to find it. Before we do the biopsy, we can do certain screening, like do blood culture to see whether we find like any organism there, if there's inflammation, and the other side, if you have like hemodialysis, to check there is no tenderness in the IV line. You need to make sure this is not the source of infection that make things. Now, these patients, if they have bacteremia, you need to check whether their heart, you make sure there is no septic emboli. Sometimes there is in the valve itself, they have like small vegetation that keep this infection going on. So you need to do some workup. So since his pain is severe, he need to be admitted to the hospital. Of course, do this workup investigation first, all this investigation, and then decide what kind of antibiotic. He need to know that this antibiotic will be prolonged. He need like 4 to 6 weeks of antibiotic. And what guide us the treatment, again, the organism, the culture we have, and how he respond. We follow up his marker itself and see how he respond to the medication.
Mm-hmm. Okay. So in this case study, they do a endoscopic irrigation of the abscess.
Yeah,
that's grown.
Usually, usually what we do first, we take a biopsy to see whether we can do to take a biopsy. This can be done with a needle biopsy to go ahead and take a biopsy itself. Now, sometimes we don't get culture. And most of the time we don't get culture because sometimes patient was an antibiotic before or he take antibiotics, so the culture will be negative. So usually we treat them empirically. Now, we need to go with endoscopic surgery when we need to do the surgery. One, if the pain is persistent, doesn't go away, even with antibiotic. That we try for 2 or 3 weeks, still he's not responding, there is inflammation, is getting worse, then yes, we need to go and irrigate and clean. Now, this inflammation sometimes can extend to other areas. He develop abscess. Why abscess? Because the organism is so severe. Now he developed epidural abscess that cause compression in the nerve. Then we need to intervene. Now there's like destruction of the bone itself, that the inflammation is so severe that bone is weak. Then he developed deformity. Then we need to go and clean. Now the role of the endoscopic that you mentioned is great, is that you do it through minimally invasive. You don't want to destroy the tissue itself. You need to go to the area itself, take a biopsy, clean the whole area. Again, for the antibiotic to work, you need to decrease the organism load. You need to clean it up. But usually, initially, we treat them with IV antibiotic for 2 or 3 weeks, see how it works. Now, if the first 2 weeks they did very well, we can switch to very strong oral antibiotic, and we follow up with the serial ESR CRB. So our guide is the patient symptom, that he see his response to the antibiotic he's doing well. Now he starts moving, he's going to the bathroom, he starts working in the ward. Oh, this is a good sign. No, doctor, you are giving the medication, I don't see a response. Now, if after 3 days, 4 days, still I have the pain, severe pain, I cannot move. You're giving him a strong painkiller, is not working. Then you need to think something else is going on. Is it like you have a complication? You have like epidural abscess. Of course, the problem, the MRI, we didn't give contrast, so we cannot tell whether there's some collection or something, or there's fracture in the bone itself, or deformity that limit his pain. Or the inflammation is severe, that your antibiotic is not responding. You have to keep in mind, you think of bacterial, vanco, for example, for gram-positive cocci and gram-negative, usually we start with vancomycin and meronym, but sometimes they don't respond. And you need to think why they are not responding. Is it maybe fungal? Sometimes they have aspergillus or something, especially if they are immunocompromised, and you need to think about it. Of course, the management of this patient depends on how he responds. Initially, you start with a simple thought, but if he did not respond, then you need to get involved in infectious disease. We need to call infectious disease consultant to get him else to help us to see what kind of things we need to add on. Now, if they cannot, and we reach a point that we cannot find, then we think of surgery. And if you want to decide whether surgery, we have to do it through minimally invasive, because we don't want the wound infection. We don't want to go on another complication. You already have so many complications. So we can do it through minimally invasive, go to the disc itself, try to take all these necrotic tissue, clean it up. And the good thing with the endoscope, that you can see everything.
Could you describe for our listeners the process of the endoscopic surgery? What considerations do you have to make? What are the risks? How do you avoid?
So in endoscopy, you need to know the anatomy, where to place your needle. What we do, we have to get into the space. You need to make sure that you don't injure the nerve. So you know where is your nerves, you know where is your spinal cord, you know where is your dural sac. So you can go with the needle itself in the disc space. We have something called Kembin triangle. Kembin triangle is the triangle between the superior articular facet, the nerve, the exiting nerve root, and the disc. So you can go with the needle in the disc space itself, and we can insert like small dilator to go into the disc itself. And then we start cleaning that area, take all this disc out under vision. You can do it with a radiology, you can do it like a small biopsy, but we can go clean it up completely, try to scratch all these end plates, the necrotic tissue. So the endoscope gives you the best vision that you can see the area well. And at the same time, since we are using saline, so we can add antibiotic to this saline, so we can irrigate that area with antibiotic. And so help first, before we irrigate, we take the biopsy first, take as much as you want, and then clean that area with antibiotic. And of course, now if the patient unstable, then we can stabilize him at the same time. We can leave like a cage, metallic cage, or take autograft, leave it in, and start fusing that area.
Okay, so I heard about taking the disc out. I was wondering, what are the implications and the complications that can arise? And also maybe I was thinking something like osteoarthritis because...
Yeah, of course, depending how much you take. Now, of course, if we're talking about herniated disc, now these discs out from the disc itself. So usually you keep the disc, he develops some form of degeneration, but they're small. Now, if you take the whole disc out, then this is the problem, because then you don't have that material between the two end plates. So you, as you said, you develop some severe form of degeneration. Usually we stabilize this segment. Now, if we take this disc out completely, now the whole thing is destroyed. Now, the disc is around 9 millimeter or 11 millimeter. So now you take the whole cartilage out. The cartilage is destroyed already. So you have big space. Now, we need to keep that space, because this is where the nerve exit. For the nerve to come out from the spinal column, you have vertebral body and you have the disc. So same thing, like you have a door. The door have to be 2 millimeter, 2 meter, at least, so that everyone can pass by. Imagine that you build up a door which is height 1.5. So you have to bend over to come out. So usually, if the disc is completely destroyed, then we need to replace it with something. So what we do, we put like certain graft. Now we can leave an autograft, take from iliac crest itself, shape it as the same space of the disc and shove it in to keep the space between the two vertebral body. And this will help keep the lordosis. At the end of the day, you want, after like 6 weeks or 2 months, the spine alignment, because you don't want the patient to go into chronic back pain. I have stiffness. Yes, doctor, you solved my problem, but now I have severe pain, severe stiffness, doesn't go away. So if this happens, then we need some form fusion. So we can do it at the same time. Through this one, the same hole, we can put like certain cage or a metallic cage, or we can leave the iliac crest itself autograft. And this will not work as a foreign body, because the body will recognize it as its own tissue. So it will help build up the bone, but at the same time we stabilize it. We put like certain pedicle screws or something to fix that segment if it's deformed. But usually, in most of the patient, you tell them, usually 80% they respond very well with antibiotic. For this guy, unfortunately, because he has so many medical problems, he needs to be aware that he's in hemodialysis, he's prone to infection, repeated infection. So maybe this will not solve with antibiotic. Then he knows that this is another option. The good thing in medicine, you always have to have another option. What to do if this didn't work? Then you have to find out another way. There is must be other way to do things. So you see how we respond to antibiotic. Now, if it did not, then we go for the surgical option.
Mm-hmm. And how quickly would we go to the surgical option? Is it something that needs quick?
No, again, according to the presentation, now, if we have certain, when to go for surgery. If there is pain, is affecting their lifestyle. This patient, for example, for 4 weeks in the hospital and he's not getting better. Keep him another 4 weeks. No, it did not work. You have to find something else. Now, if there is some neurological compression, epidural abscess or something which is compressing in the nerve cord, and now you're having weakness in the leg, then you have to go and decompress the nerve. If you have deformity, the destruction of the tissue itself, when the inflammation in the disc, it's become so big, sometimes it affects the tendons, the muscle itself, the bone. So patient develop deformity. So we need to correct that deformity. Then we will decide about the surgery. So it's an ongoing process. It's nothing like, okay, for example, say my mentor used to tell me that you make a plan to go to a certain country and then, something happened. Okay, then I make another change the plan to do it other way, enjoy it in other way. So the same thing, we'll see how it will go, but you need to know that to manage this patient, you need to get multi-specialty. For example, I am a neurosurgeon, neurospine, so I do surgery, but at the same time, we get physiotherapy, we get infectious disease. Initially, we can do with antibiotic. We can leave them like with a brace, with antibiotics, see whether he can move with the brace. Sometimes they do very well. You can keep them like in a brace. We call it TLSO brace or Milwaukee brace, which will hold the spine. Usually, we tell him to wear it when he turn in bed. He sit up, he wear the brace. Oh, he's working very well with the brace. It doesn't mean that the brace is working, but the inflammation is little that his body will heal it up. Now, if he cannot, then we will help him.
The patient evolved favorably. After 48 hours, he reported significant pain relief, 2 out of 10. In all the samples, Pseudomonas aeruginosa was isolated at 48 hours, and the antibiotic treatment was adjusted to intravenous meropenem. Acute phase reactant values had improved significantly after surgery. Due to the good clinical evolution, the patient was discharged 7 days after the procedure with an indication of an intravenous antibiotics for 3 weeks and oral antibiotics for 3 months. The patient was monitored with clinical and laboratory tests, which is complete blood count, erythrocyte sediment rate, and C-reactive protein by the infectious diseases and the spinal surgery teams. 3 months later, he came back to the clinic and reported back pain. Laboratory tests were normal, so the ESR was 11 and the C-reactive protein was 0.32. So the patient has had all these antibiotics and then he comes back with a little bit of pain.
Yeah, this pain, as you said before, this is because of the degeneration. This disc damage. Of course, I'm not back to normal. I have this back pain. But you ask him, what type of this pain? You find it is more like degeneration. This pain will increase when he change in position, turn in bed, going in the car, coming out of the car. Usually, it does not affect his walking. This is all because the stiffness, it will increase with cold weather. So we tell him, be careful about the cold weather, the air conditioning. The same thing, smoking. If he's smoking, we tell him to avoid smoking because smoking will increase the degeneration. Usually, we'll tell them exercise. Now, if he did not respond to this one, still have this stiffness, then we do MRI again, check what it is. Usually we'll find that this disc is degenerated. We can do some kind of pain intervention. We can give like facet block to that area, help him. But we usually tell them hydrotherapy, keep doing the exercise. We do certain kind of McKinsey. Of course, you do DEXA scan, check whether he have osteoporosis because if the bone is weak, the joint itself will be weak. And this will cause his back pain. So we check DEXA scan, make sure he doesn't have osteoporosis. With all this, I'm managing well, then that's it. Leave him. Don't touch him. Just keep encouraging him, do the exercise, wait, avoid smoking, exercise. He's managing well. Now, if he still have pain, then we can talk about giving him some form of like facet block to that area. Again, we can confirm that. We can do something we call SPECT. This is a nuclear scan, which can show that there is some inflammation at the disc itself or at the facet. Then we know that could be solved with injection. Now, again, if the pain is severe, then the other possibility is to do fusion to that area. But he's not having any more infection now after 3 months, 6 months usually. And as you said, you check him up with ESR, CRP, serial follow-up. He's doing well. Now, this pain, we need to tell him this is different than what you had before. That before you have pain all the time. Now the pain only when you're changing position. This is because you lost flexibility because of that space segment.
So you've practiced in America and Kuwait.
Yes.
What are the biggest differences or challenges that you have experienced between the different medical cultures?
Yeah. In United States, it's more like structure. It's like everyone go with his specialty. Usually we have referral from the rheumatologist from everywhere in the United States to your own specialty. So you don't pick up the patient. You don't run about the patient. They usually work in a practice and you work with other people. So the other people will refer to you, usually the general practitioner, the rheumatology, the physiotherapy, the chiropractor. Now the patient will go to them first. And then if they didn't respond, they will refer them to you. In Kuwait, it's different things. The patient will come to you. Sometimes, I'm a neurosurgeon. Usually the patient will come. Oh, I have back pain. How many days? 2 days. Of course, come on. 2 days you're coming to a neurosurgeon. This is usually should be solved with the polyclinic itself. This is why you have to work up. For example, say you saw me. Usually we see in the clinic 70 patients, but at the end of the day you find maybe 2 or 3 of them need surgery. Now the rest, usually they need physiotherapy so you refer them to the other area. So it's like you work up for the cases itself. So you see the patient themselves because they will come to you. I have back pain. How many days? How did you respond? Did you do the physiotherapy? No. Did you do the pain management? No. Did you go to do rheumatology? No. So you have to do the all workup first, which is exhausting a little bit, but it's rewarding because you can solve them. Sometimes, we see patients, sometimes they come with numbness, tingling, and then, find weakness. Then I diagnose them with multiple sclerosis, which is not, my specialty. I'm a neurosurgeon. Usually they should go to the neurologist first. But, again, depend on here in our community, we have in Kuwait, the patient themselves, have access to all the specialty. So usually they go, okay, I want to go to the top and then come down. In the United States, in Europe, different. Usually they go to the polyclinic first, and then they start referring. Here we go directly to the king.
I mean, we have primary care, which sort of filters is acts as a filter, but it's fascinating to hear that it's actually interesting because you get a broad scope of how you
have access. Because here in Kuwait, the health system is that you have it's subsidized by the government, but the patient have access to go to any other area specialty, and they have their own insurance, so they can go to anywhere they want. They can go to the cardiologist. For example, they have chest pain. Now chest pain, maybe heartburn. You go directly to the cardiologist himself. Okay, the cardiologist ask him the question, everything. Oh, you have nothing. You go for the GI. But you hear the patient themselves, they pick their doctor, and we need to teach them. Okay, how to go. In Europe and United States, usually the main first line is usually the polyclinic. They are the one who filter the patient, and sometimes now this will make load on them. Because when they see a lot of patients, sometimes they cannot have access. It takes too long for them. Then it's difficult. They have to go to the ER or something. In the United States, you see our ER is so busy because they cannot find appointment in the polyclinics. Then they come in the ER, and then you see everything, and then you can catch them. So there is pros and cons for each one. But in Kuwait, we're blessed that, patient can come to everywhere. They can see everything. And the good thing that you can see, and you keep your knowledge, what you do. With time, as you said, 20 years practice, you forget other specialty because you focus in your own specialty. But again, you need to learn about other things because sometimes happen some complication during the surgery itself. Like we have 2 patients after we did the surgery, we did everything well. And then 2 days later, they become weak. Then we find that he have Guillain-Barré. So you need to recognize it because if you do recognize it, then you can treat it with IVIG, you do lumbar puncture, and then you work them up. You have to have knowledge for each specialty. Oh, I have to call somebody to help in this management in this case.
My last question is do you have any advice to students or young doctors who are interested in neurosurgery as a specialty?
Yeah. For me, I'm biased. Neurosurgery is a great thing. We deal with the brain, peripheral nerve, spine, tumors, functional neurosurgery, vascular. It's a very tough specialty. You have to spend time. I spent 6 years in residency and 1 year fellowship. And again, if you finish even after 7 years, you are in the first line. Then you need to keep learning how to get stuff. It's very rewarding. And the patient usually will love you because you help them. You get them back to their own function. Usually if they have tumors or they have Parkinson, epilepsy, back pain, leg pain, you get them back. It's a tough one. You need to study well. And of course, if you love it, then you need to you need to be in right time, right place. I told you, I discussed with you that I thank my God that I did my residency in the United States because it's very, very, very rewarding. You can learn from so many mentors and you do it. So you need to be in the right time, right place. So you have to keep your mind open. You need to do your SMLE. You need to do your Canadian and keep it. You will not lose it because you already have the study. Then you can keep it. If you find it, even if you didn't find residency, you can do later on fellowship. You can do anything else. If you want to work in any other area. Of course, we graduate from medical school. Maybe there is more than 100,000 medical students around the world. You need to make, you think, when I graduated from Kuwait, I thought this is the only university. I didn't know that there is other university. I think we are the smartest people in the world. But then you look to the other, okay, there's one in Tokyo, in Asia, in Europe, in Africa, in America. How do we make the standard? We need to have an exam, and we passed the exam. If you pass the exam, this means that you studied very well. Now, if your English is good and you can do the USMLE, definitely do it. It's a standard exam. This you can match yourself with the other people. You check how much you grade, how much you study, and you are doing well. If you score like very high score, this means that your knowledge is good and you convert yourself to the other. We have to have a standard. Same thing like Greenwich. We say the time. You cannot do the time from this. We go with the UK. This is the Greenwich time. We know the time. So for medical school, I think the Greenwich time, our USMLE, the Canadian, because they have the standard. Now, of course, they have one in Europe. They did the Europe exam. But you need to do the exam. Everywhere else, you need to do your standard to know where you are in comparison to the rest of the people.
Fascinating.
Perfect. Thank you very much for the reporting. It was very interesting.
Thank you for your time. Yeah.
Thank you for your visit in Kuwait. You came in the summer. It's very hot here.
It's hot, but it's dry. So it's not English hot. English hot is a lot more sweaty.
You survived. You survived. 60 degrees Celsius.
Yeah.
They are very good.
Yeah. And there's aircon as well. That makes a difference. So thank you so much. We really appreciate it. It's fascinating. So thank you for your time.
Thanks.